All right, well, it's 8:01. We'll get started. I want to welcome everybody back for our next season of Department of Medicine Grand Rounds. We are delighted to have Dr. Tony Thrasher from the Milwaukee County Behavioral Health Division to talk about a topic that is very relevant and to do a more in-depth introduction. I'm going to hand it off to Dr. Siobhan Byrne, who is our Director of Wellbeing in the Department of Medicine and a professor in gastroenterology. Siobhan?
Thanks, Lynn. So we are thrilled to welcome Tony Thrasher here today to present to us on this topic. As Lynn said, he's currently the Medical Director of Crisis Services for Milwaukee County Behavioral Health Division. He's the immediate past president of the American Association of Emergency Psychiatry and the current president of the Wisconsin Association of Psychiatry and the Wisconsin Association of Osteopathic Physicians and Surgeons. He's also a board member for the ACP Coalition on Psychiatric Emergencies and a current member for the Association of Threat Assessment Professionals and International Association for Healthcare Security and Safety. So as you can see, well-versed on this topic and kind of well exposed to it all. He's also the recipient of numerous awards for both teaching and clinical excellence and has presented multiple grand rounds on a wide range of topics that are associated. We're thrilled to have him here today to speak to us today on this topic of workplace violence in healthcare, current state, best practices, and reducing risk. Thank you.
Thank you. Thank you not only for having me, but thank you for having an interest in this topic and putting it at the forefront of your grand rounds for this year. I think it's a really important topic for all of us. And today is going to be a very broad overview. A lot of slides. Some of them we're going to spend a lot of time on. Some of them I'm just going to bookmark for you to reference later. You'll have access to this entire presentation so you can review it and don't feel like you have to take notes or completely grasp it the first time around. I'm hoping that by the end of this hour, you'll have some answers. I also hope you'll have a lot of questions and thoughts on how are we doing this in our house? What are some things we may want to change? What are some things we may want to accentuate that we're already doing that are really good? It's a very broad topic. It's hard to fit into an hour, but here we go. Workplace violence. The relationships and disclosures, I have nothing significant. Dr. Byrne was kind enough to notice a lot of my projects, but none of those are tied to today or any compensation in that particular context that would be a conflict. So here's our brief objectives. We're going to talk about what workplace violence is, and specifically how it can be more complicated in healthcare. Workplace violence has actually had society's eye for a while now, but they're really starting to see how much it affects healthcare and how we are a different entity when approaching WPV. We'll talk about some different techniques that can reduce your risk. I'm going to talk a little bit about agitation. Now, mind you, the treatment of agitation is an emergency medical condition as defined by EMTALA. That's a whole separate talk that we could do anytime you want, but that's really a little bit more specific to your inpatient ER world. WPV can affect anybody. And in fact, WPV is often of higher stakes in the ambulatory setting, as you guys are well know. And then hopefully by the end, we'll also get to some talking about threat assessment. Now, some of you may hear that and say, oh yeah, I'm familiar with that. Some of you may not. This is a well evidence-based practice in a multidisciplinary way, including not just physicians, but other members of the hospital system, other members of the community, to get together and assess threats over time and mitigate your overall risk. It lowers both effective and predatory violence. And we'll talk about those two a bit more. But as a teaser, predatory is the rare part that is very criminal and intent and is planned. Effective is people that are getting upset in the moment, and emotions lead to anger. Believe it or not, in healthcare, effective is far more common, the violence that we see, but predatory is the one that usually is the one that we're worried about the most because it has the most negative outcomes. My contact info is there. That is a publicly discoverable email. You are welcome to reach out at any time. Like I said, a lot of stuff today. We'll be moving pretty rapidly, so I can understand why you might have questions that we don't get to. Or if you're like me, you think of all your best questions like a week later. So feel free to go through Dr. Byrne. Feel free to reach out to me directly. I have no problem with people emailing me. I usually get back to you in about 24 hours. If there's some questions here you just want to keep on talking about or things you may think about later, perfectly fine by me. Very big area. Like I mentioned, every section is its own work group. So you may find one of these things where you're like, oh, I wish you had talked about that just a little bit more. If that ever comes up, email me and we'll talk about it in more detail. Now, here's one that we'll talk about more at the end, but I want to lead with it because it's so important. If the idea of approaching workplace violence is how do I kick patients out? And yes, I used a pejorative term on purpose there. How do I remove them from our services? The thing I want to warn you about is in the big picture, that doesn't tend to work. Not Saying it doesn't have to happen every now and then. I've been there. I'm not saying there aren't exceptions to every rule, but most of the data notes that access to healthcare in of itself is risk reduction. So usually some of the worst events I've consulted on with the most fatalities was shortly after somebody was removed from care. Because we don't work in a prison. We don't have walls and guards around us. So when you remove somebody from care, it does not keep them from coming back to your place of business. So we'll talk about this a bit later, but this is more about sometimes we are meaning to do the right thing in the moment and we may be making the overall situation worse without knowing it. You'll also hear me refer to this a lot. I talk about it all the time when it comes to healthcare and change. In healthcare, we are big fans of process. We like to see an event, didn't go well, so we create a new process. We create forms, we create pathways, we create ad hoc subcommittees. And I don't say that with any malice, but it is what we tend to do in healthcare. And so what I remind most leaders is all of that is moot if you don't change the culture. Culture eats process. So you can have all the process in the world, but if the overall culture of your team is, we shouldn't have to be doing this. These people shouldn't be here. You're going to be facing a very uphill battle as far as changing things and making people safe. So next couple slides are not going to surprise any of you because that's why we're talking about it. But just to anchor ourselves on why this deserves to be a Grand Rounds topic, what are we seeing now? Well, we're seeing a lot of violence. This was a JCO journal, looked at 5 different hospitals only over a 2-week period, and they're seeing aggressive acts at least every work week. Now, oftentimes more verbal than physical, but nothing says that verbal is not just as traumatizing. The most common lead-ins, not surprisingly, something to do with meds, something to do with waiting, and something to do with, believe it or not, food service. People being hungry and thirsty. One that I thought would be on there, but isn't, is nicotine administration. I think as a whole, systems have gotten better at getting nicotine on board quickly. This isn't as big of an issue in the ambulatory sense. Most of this data in ambulatory sense came down to waiting for care being number 1 and medications being number 2. Now, a lot of this can be mitigated. 3 out of 4 cases were mitigated without needing to do anything other than verbal. However, that other 25% needed a lot more staff to kind of calm things down than just one person. I give you some other data points. AHA has noticed the increase in violence. ASEP has noticed significant increase in violence. Nurses, very scarily, the nurses have now become, our registered nurse colleagues have now become one of the most violent professions in America as far as risk, surpassing law enforcement officers in some studies as well. So this is an area where it's really affecting all of us, all members of the treatment team, whether you be inpatient, outpatient, or something in between. Now, I mentioned to you I wanted to call out healthcare because healthcare is just a little bit different. And I think this is what people are noticing. You can't just go and say, oh, well, I did this talk at an insurance agency, and I did this talk at the welfare office, and I did this talk at Child Support Center headquarters. So I'm just going to extrapolate all that to your clinic and we'll be fine, right? Probably not. Healthcare is a bit different. First off, this is not for the ambulatory folks, but for hospitals, you have EMTALA. We can't make people stay away. That was always my joke. I ran a psych ER for about a decade. And I said, if somebody comes in and shoots me on a Monday, if they get out of jail the next week, they can still come back to the ER. I'm probably not going to be the person to see them, but they can't be blocked from certain degrees of services. We also are dealing with people at their worst moments. Higher acuity, higher stakes. And be honest, a lot of you, particularly since you are academic healthcare professionals, you're often turfed to by other entities, right? You're not getting easy cases. We get a lot more zebras than horses sometimes. And so you're getting people that have already been frustrated by other parts of the system, and they're coming to you and you're the tertiary or you're the quaternary. And after a while, you start receiving a lot of that extra aggression and upset feelings, even though you did not cause it. And for those of you that are more on the hospital urgent care side, you're dealing with 24/7 operations. If any of you have ever run a 24/7 operation, it is hard to staff. And it's hard to staff with consistency and reliability. There's often going to be variability on weekends and third shift and other parts that are harder to staff. Just as a quick reminder, if you're ever doing 24/7 stuff, for every 1 employee that you would think of, you need 2.5. And it's a lot to keep that going and keep the quality high. Now, those are the factors that are not changing. That's just how healthcare is. Now, these are the factors that may change in healthcare that we can really focus on. If there was a way to star a slide, this is one I really feel heavily about. We're not going to spend as much time on it today because it's a special topic of how we handle dissatisfied patients. I think you get a lot of training in how we deliver bad news. How we deliver dissatisfied or how we handle dissatisfied patients is a bit different. So first off, things do go bad. we are dealing with high stakes. And even if you do everything right, things can still go bad. Or things actually went perfectly, but you are still being blamed for it not going the way people thought it would. There's a big issue with service recovery. It's something I teach all my docs. Service recovery is something the business world does very well and healthcare does not. And service recovery means even if you're right, and you often were right, and you did nothing wrong, somebody's still upset. And how do we handle that? How do we say, I'm sorry that you're feeling bad. I don't think we did anything wrong here, but that all the same, you came to us looking for something, you feel like you didn't get it, let's talk. That's more often going to be a managerial or a supervisory intervention, but it's good to have those skills over time. And also, we have a lot of different people that work with the patients we serve. And for those of you, you may have noticed, we've got big healthcare systems, and they're getting bigger, and they're banding together on the dance floor and getting even bigger. And so a lot of times, you may not even be dealing with the person that's upsetting you. It may be going through PR, it may be going through HR, patient services. There's all these other people connected that may be making your life and your risk higher or lower without you even knowing it, because the person's not complaining to you. Some of the most serious cases I've ever worked on was when I was brought in by HR to consult on a patient threatening a doctor. And when I went to talk to the doctor had no idea the person was mad at him. In fact, if anything, the doctor would say, Tony? I've known Tony forever. He's been seeing me. Everything's good. And I'm like, well, that's not what he's telling these other people. So there is this disconnect that is not our fault. It's just something that happens in healthcare as we get bigger and bigger and bigger. Private practice, you're probably not going to have that big of a disconnect. Couple things. This every once in a while shows up on boards, believe it or not. When it comes to violence, OSHA delineates it as 4 different types. This is what you see in the hospital settings or ambulatory settings. Type 1 has nothing to do with your site. You were just wrong place, wrong time. Somebody's a patient, they're leaving your clinic, and they get mugged in the parking lot. It's not because you were a clinic. It's not because they were a patient. It just happened to be a location. It is the rarest form in healthcare. Doesn't get cataloged a lot. The most common is type 2. That is basically coming from the customer to us, coming from the client to us. Type 3 can happen too. That happens number 2 sometimes in healthcare, which is horizontal violence, us to ourselves, worker to worker, supervisor to subordinate, etc. The ones that tend to have, unfortunately, the most fatal interactions is type 4. This is where it actually doesn't have to do with the healthcare, but your healthcare worker, their private life bleeds in to the healthcare environment. Because once again, you see this a lot with domestic violence. Somebody can avoid their abuser, but if their abuser knows where they were, and whether you're working hospital or clinic, they know what hours you're open. They know how to get there. Sometimes the violence happens there, unfortunately, because the person has to go to their job. Just going to throw a couple articles at you. I'll have some more at the end that I think are also take-homes. OSHA is trying their best to really look at this. While they're looking at psychiatric facilities, they're doing the same at all aspects of healthcare. A lot of law enforcement overlap. We won't go deeply into this, but this is something to think about. A lot of hospitals turn to law enforcement, and that's fine. I'm not saying that's a bad move, but as someone who works with law enforcement frequently, I remind people, when you call law enforcement in, they're going to do law enforcement things. So very often, I think what healthcare is upset about is when we kind of cede our control to law enforcement, we are often upset with how they have chosen to handle it. We cede the scene, and we are not controlling it internally, and we're asking an external service to come consult. They're going to do things in their way, and their way may not often be a way that we in the end are very happy with. Sometimes we may be, but sometimes we may not be. In fact, there's decent evidence that having law enforcement present can sometimes escalate things more so. Not saying there isn't a need for them, but they're often better coming in as a consult on severe cases as opposed to being ever present. And I don't know if any of you have been through this. I have. It's unfortunately, I hate to say this, not incredibly uncommon in the world of psychiatry, but I know it happens in other fields of medicine as well. So this is just another article that has come up, and I'll reference several things by Dr. Roselle later today. He's a close friend and colleague, and he writes a lot of good stuff on this. And of course, how about non-articles and just headlines? I could have taken up 10 slides with this. The focus on violence in healthcare and the risk that we face every single day, particularly when you're already looking at high levels of burnout. You're already looking at high levels of moral disengagement and moral conflict. This is not something we want for our field. And I don't think it's a reason that anybody went into healthcare. Most of you are altruistic and caring and empathic. It probably never crossed your mind that I need to be prepared to protect myself. That's why this is such an important topic. So the next 5 to 10 minutes, I want to be a little more specific about when you're trying to decide what could be violent and what couldn't be. I think one thing that people get too caught up in is diagnostics. Now, I'm a psychiatrist. So as a shrink, I'm used to hearing people say things like, oh my gosh, they have schizophrenia, they have this, and that's fine. I'm always happy to consult and educate on the role of mental health in violence, even though it's pretty minimal. The majority of workplace violence incidents have nothing to do with people with mental health illness. Actually, if they did, it'd be much easier because usually then people are kind of on somebody's radar. There's treatable symptoms, there's a history known. But usually when we're seeing workplace violence, it's all more common for the aggressor to not have a mental illness, but often be kind of new to the scene or have other symptoms I think you should be paying attention to. So let's go over those for the next 5 to 10. So as I mentioned, whenever I'm consulting on this, people want to get into the diagnosis. That's fine, but there is really no great ties between diagnosis and dangerousness, period. So I guess my point of view is if you want to take your time trying to find a diagnosis, that's great, but to what end? What you really want to look for is symptoms. The diagnosis can take you down a rabbit hole. It can be a red herring. It can take your mind away from what you really need. Most data, most best practices, this includes not just us, this includes FBI, CIA, NSA, Secret Service. They focus on symptoms. That keeps down the actuarial bias. It also helps you appreciate that anything can happen to anybody at the right time. You can have a patient that everything has been great and they're your favorite patient and, they know you see them in the grocery store, you smile, whatever, but you give them the right set of circumstances. A death of a parent, followed by a divorce, followed by a job loss, followed by some public humiliation on social media. People can get different. And it's not about a diagnosis, it's about the symptoms. What has happened to them recently is markedly more important than what pops up on the DSM or the ICD. And I think to this point, this is what I often see when I'm trying to teach people about this workplace violence is you can't treat it like your typical risk assessment, right? Our typical risk assessment is things like asking about suicide and homicide. And, I'm sure it's not news to people. Most people that are planning on doing harm to others don't tell you that they have homicidal ideations. So these questions in of themselves, despite being baked into our core, and they have some utility in the regular world of risk assessment, but in this world of risk assessment, those questions aren't going to bear much fruit. This quote, I think, kind of sums it up the best. I'm going to refer to this article at the very end of our talk, so I'll give you the full citation there and why I think it's kind of a seminal publication. But I like this particular quote I pulled out. A person at risk of committing any violence, mass violence, workplace violence, etc., may not present for overt psychiatric symptoms. Instead, because of acute psychosocial stressors, threats, or indirect statements of intent to kill others. I have seen this in my entire career. I've been doing this almost 20 years now. When it comes to this type of externalized, impulsive workplace violence, these grievances that turn into dangerous action, it is almost always psychosocial stressors. Now, I'm not saying that people don't have other things going on. They may have other diagnoses, but it is almost always. There's always that thing that kind of broke the straw that breaks the camel's back, so to speak. Something has happened. It doesn't just magically one day wake up and they feel that way. So by focusing on the stressors, by paying attention to patient dissatisfaction, we can mitigate a lot of this risk. So what should you look for? I don't think this will surprise you, but let me just put it on paper since we're doing an educational session. Anger. Usually, grievances. We're going to talk more about grievances in a bit. That is something I like to talk about even in a separate session in a much more depth, like how do we handle dissatisfaction? How do we handle grievances as an organization? One thing I already alluded to that I worry about is the people handling the grievances are not you. They're other staff for the hospital, and they may not have your interests in mind, and they may have the system's interests in mind more so than an individual person. Keep that in mind when you think about how your institution handles formal patient grievances. Do people feel bullied, abused? Do they have access to firearms? Of course. Are they suicidal? There's a lot of links between suicidal people who also externalize violence. Those are not a dichotomy per se. In fact, good old CSF findings from those that die of both suicide and those that died after being violent perpetrators have very similar low findings of serotonin preceptors. And feeling rejected is a very important one. You may say, well, what does this have to do with us? When we remove people from services, even if it's for all the right reasons, and the onus is all on them for their behavior, they will feel rejected, and that is a risk factor in of itself. Isolation, DV is a big problem. Misogyny, if I had to pick one symptom that has been shown up in the most studies for mass shootings, so that's a very small subset of workplace violence, but mass shootings in particular, probably the most common threat is misogyny. in many, and I don't mean a little bit of misogyny. I mean massive amounts of misogyny. And of course, prior history of violence and social exclusion. I just like the title of this article. If you can't join them, beat them. That is a very common thread in aggressive people, is feeling isolated and excluded, and I was rejected, and therefore I'm going to do something. Now, that I'm not saying it's justifying it. I'm saying these are the symptoms you should look out for. Now, one quick exception. So I can, as a psychiatrist, tell you, yes, there are rare occasions in which the mentally ill are more violent. This is it. And it's not all psychosis. It's a very small subset of psychosis, which we'll cover in the next couple slides, because this is the one time where if you're dealing with psych symptoms, we're like, let's look at this a little bit deeper. Once again, you probably know this. You probably heard it from your own department of psychiatry. The majority of people with schizophrenia or other psychosis will never be harmful. Ever. The majority have never even been hospitalized. It's just we're seeing a selection bias of a certain high acuity portion of people who live with psychosis and schizophrenia. If people with schizophrenia are going to be violent, they are markedly more often violent to those close to them. The rare times that there have been fatalities in these cases, it is almost always who they live with. Loved ones, caretakers, maybe like an in-home healthcare worker, but it's not the public at large. People don't get psychotic and just start roaming the neighborhood looking for somebody to harm. That is very, very unusual. And actually, to get into even more details, one reason there's less fatalities here is when people with schizophrenia tend to be violent, they don't use firearms. They use blunt instruments and knives, which have a much lower lethality of attack than people that use firearms. When people with schizophrenia use firearms, unfortunately, it's usually to direct the violence towards themselves. As with most fatalities and suicides, they are gunshot wound mediated. There are a couple symptoms to keep an eye out for. You may see these, you may not. Maybe you'll be consulted on these, but these would be ones I'd probably reach out to your whoever your psych CL is and say, hey, can you help me with this? The big ones are paranoia and persecutory delusions, which makes sense, right? If you truly think your life is in danger, you're not being homicidal, you're being protected. So when you're interviewing those people, don't try to prove it's not real. That doesn't get you anywhere. It doesn't mean you've got to agree with everything they say, but don't just say, oh, well, let me show you this data as to what. If you could data them out of it, then it's not psychosis. That's the whole idea of what psychosis is. I also find that a lot of people ask about suicide and homicide when people are psychotic, and that doesn't help either, because they don't see themselves as being suicidal or homicidal. They see themselves as being protective, acting in self-defense. I've unfortunately seen cases where mothers have tried to kill children, not because they hate their children, they love their children. They believe their children are being persecuted by external forces, and they're doing their children a service by taking them out of this world before they can be tortured or sexually trafficked or whatever else their psychosis may have led them to believe. So our traditional way of interviewing for this doesn't work. You have to alter it a bit when you know you're dealing with something that's more psychotically mediated. And these are some of my favorite questions when it comes to psychosis. I don't even use the word aggression, violence, harming others. I say, it sounds like you're really worried about this Tony person. Yeah, I am. I don't like him. I think he just doesn't make me feel good. Okay. Well, if you ran into that person on the street, what would you do? Oh, well, I'd pull out this gun I keep on me at all times and shoot him in the face. Now, he would not have said that if I didn't give him the clinical scenario. And so sometimes when we're interviewing for these types of cases, it's good to get out of our typical checkbox EHR modality and get into some more what ifs. Keep it open-ended. Don't let people close-ended question their way out of this. It's a really good thing when people are psychotic to go down this wrong. Because once again, if you're psychotic, they don't see anything that they're doing is wrong. So you can't use ethics and morality or fear of jail. To them, they are truly protecting themselves or those that they love. Now, I mentioned agitation. That in of itself is a whole nother scenario, but since some of the principles of agitation overlap with workplace violence, I want to spend a couple slides on that too. So first off, I already mentioned this, agitation is not a psychiatric thing. Agitation is a medical thing. Agitation is an overall emergency medical condition under EMTALA, meaning we have to stabilize it and take it very seriously with something other than just restraints or call security per se. I do find that oftentimes the issue of agitation gets conflated to all psychiatric patients. I mentioned earlier my time running a psych ER, saw hundreds of thousands of people. The most severe incidents I saw were in non-mentally ill people, probably because they weren't used to feeling that way. It was their first time feeling agitated. They felt very out of control and outcomes were much more severe. But when it comes to people that are agitated, I know it's hard. Nobody likes being threatened. None of us do. We're human beings. You're going to react in a certain way. But we got to make sure that we're not getting people talking about, well, those types of patients shouldn't be here. Because once again, this is where culture eats process. If your true belief is, I shouldn't have to be dealing with this, these people are bad and they should not be here, the chances of you actually modifying your process for things to get better are much more difficult. Because people have a right not to be agitated. Most of the agitated people I work with are not in a good mood. They're not having a good day. They're not enjoying themselves. They don't sit down and say, ha, look what I did to that healthcare team. They're having a pretty crappy day too. And since we treat all sorts of target symptoms, we treat pain when it arises, we treat fever, why would we not treat agitation? And I like to use the pain analogy a lot because very often when a person presents to you in pain, you have to treat the pain first, get it out of the way. Otherwise, you can't be a good diagnostician. The pain is confounding your ability to examine and make a good medical decision. Same with agitation. If you can't clear it out of the way, it's very, very difficult to know what the heck is going on. And I've seen people die because the agitation kept people from evaluating them or treating them when in fact there was something very, very serious going on. Just another data point, it's a little bit older, but it's a really good one. This was actually had a selection bias. They were looking at county hospital EDs, and they were looking to see who did it well, who handles agitation well, who was able to decrease violence the most. And what they found, not surprisingly, was recognizing the risk first, not ignoring it, not hoping it'll go away, not turfing it to somebody else to take care of it for them, and shortening the time for de-escalation. I will say the term chemical restraints is very much out of vogue, but it was not at the time of this article, so I leave it here for the purpose of accuracy. But the idea is basically when somebody's not doing well, don't sit there and wait, get on it. We train hospitals in treating agitation like you would do a code. It is a code, it's just a different type of code. So much like you do a respiratory pulmonary code, or a cardiac code, pardon me, you practice it, right? You know, you've got the tube, you've got the IV, you're going to be documenting, you'll be giving the orders. The same has to happen with agitation codes too. Who is doing what and how do we practice it so it doesn't feel so haphazard? So once you get the agitation, what do you do? Once again, I'm not going to go into full detail on this. I just want to give you the resource. Maybe you guys are already doing agitation really well, but if you haven't, and this works in ambulatory settings just as well as anything else, is Project Beta. This is something a bunch of us put together it's been been over a decade now. So we got to reboot a couple of the articles, but it's called The Best Practices in Evaluation and Treatment of Agitation. It's the most downloaded article ever in WGEM. It's all free. You can just Google it and find it. You can go through this link, whatever you want. There are no charges whatsoever. It's 6 very similarly themed articles on handling agitation. They are built to be used for journal clubs. They are built to be used for non-physicians as well. When it comes to this topic, while we're talking physicians to physicians here, the real topic of workplace violence is it takes the whole community. Because you guys aren't usually at the front door welcoming people, right? There are a lot of people that have the opportunity to de-escalate and mitigate risk. Or conversely, there are many people that have the option to make people worse long before you see them. So this needs to be a teamwork environment, and these articles work like that. That's just another picture of that. Now, to de-escalate people. This is the same no matter where you are. Most of this stuff you guys already know, but I like purpose. Stay away from you statements. That has been well proven in functional MRI studies that when you lead with you, we tend to get more defensive. Even if I say you are the most talented physician I've ever met, you're still going to be on edge because I led with the word you. Watch your posture, your space. Try not to get behind people. None of us like it when people are behind us. It's going to make us more defensive. It's going to make us more primal. Our autonomics are going to take over. The frontal temporals are going to shut down and the amygdala is going to take over. If you're uneasy, the patient is too. That doesn't mean you don't have the right to be nervous. Your autonomics are going to be doing what they do because they are autonomics. But the more we can train ourselves to be a little bit more calm, at least on the surface, it keeps the patients from being upset as well. My favorite de-escalation take home is right here. So get ready. This is about to get shrinky. This is about to get touchy-feely for about 3 minutes. I love this quote. It works. I have de-escalated thousands of people with this approach, which is seek first to understand, then to be understood. Okay. And the reason I say this is it goes against everything we've been taught as doctors. And I'm fine with that. Nobody's wrong here. I'm just pointing out there's a mismatch between how we've been taught to operate, how we operate, and how this works. We are taught to walk in. I've reviewed your chart. I'm going to do an examination. I've got the knowledge here to make you feel better. Let's go. But in reality, when people are agitated, that's not a good approach. They want to be heard, even if you know what's going to be said, even if you don't think there's anything you can do about what they're about to say, even if you feel like it's going to be, quote, a waste of your time, end of quote. It is really important when people are agitated. They probably have not been heard. They probably have not been listened to. So I try to give them the first 5 minutes. I'll say to them, listen, I've talked to the nurse, I've read your chart, but I really think you're having a horrible day and I need to hear from you. Can you tell me in your words what's going on? Now, that doesn't mean I'm going to let it go for 30 minutes. I have a schedule too. But if I can give them 5 minutes to talk, that's my part of understanding them. And sometimes, to be honest, I get good things I didn't know. I learn things from that untapped 5 minutes. Then I move into, okay, now that you've shared that with me, as someone who knows a lot about this stuff, let me see what I can do to help. Here's what I can do. Here's what I can't do. But seek first to understand, then to be understood. It seems simple. It seems after school special. And I can tell you it works. And the reason why it seems so simple, we don't do this. Doctors don't do this. And I'm not saying we're bad. It's just not how we're built. We've already done the assessment. Why would I go and listen? I already know what's going on with you. Why would I then listen to you tell me what's going on with you? It seems somewhat backwards. It may even seem like it's, quote, a waste of your time since you've already got the right idea as to what to do. But to somebody who's agitated, it's really important. Your time, attention, and respect and kindness are just as de-escalation as medications. Speaking of meds, yeah, I'm going to talk about it, but that takes up so much time. I just want to give a couple shout outs. And this depends if you're ambulatory versus inpatient. Although I've worked with a lot of ambulatory clinics who have built medication protocols into their de-escalation. Of course, it's volitional. It's not going to be intramusculars, but there's a lot of ways where we've been able to de-escalate patients in ambulatory clinics with PRN, PO meds, or sublinguals is also very, very popular. When it comes to violence and agitation, most providers overemphasize the risks of psych meds. I've taken a million consults where somebody's on the phone. I can hear glass breaking in the background. And I'll say, what have you given them? Oh, they don't want meds. I'm like, okay, but they're like attacking your people, right? I just heard them break the fire extinguisher glass. Their ability to say no to meds left a long time ago. This is risk versus risk. And the risk of them hurting somebody with that fire extinguisher is nearly 100%. The risk of your intramuscular antipsychotic giving them torsades is probably 0.03% is where we're at. So just be aware that while people get caught up in the risk of the meds, very often you're missing the much larger risk of untreated mental illness and untreated agitation. Also, we tend to wait too long, or we don't treat it as an ongoing issue. Once again, with pain, if you gave me something for pain and then you said, hey, how's the pain? I'm like, oh, it's still bad. It may even be worse. Okay, sorry, that's all I had. We would never do that. We would keep on treating pain to some accepted endpoint. Same with agitation. You got to keep doing this. It's not just a one-time shot. I went to that one talk with Thrasher and he said to use this med and I've used it and now we're done. No, you got to keep on treating it like an active emergency medical condition, which it is. And then lastly, I just want a quick little shout out on restraints. When I see people say we're going restraint free, which I know this is not an ambulatory comment, this will be more for the inpatient world. That's great, but it just means you have a selection bias for who you treat. That'd be me having a hospital that says I refuse to do ICU. It's like, okay, well then you're just not treating the sickest of the sick. You can't just restrain people and not treat them. That will not calm down anybody. Nobody would be calmed down by being tied to a bed in a vulnerable position and then not having any of your needs addressed, right? That becomes punitive. What you're saying there is that it's behavioral. You're trying to threaten them into getting better, which if any of you have kids also know that probably doesn't work. So if you're going to put somebody in restraints, medicate them. Medicate them to get them out of restraints. Back when we had our PsychER, any restraint episode that lasted over an hour had to be overseen by me as medical director. Because to me, there's no reason we can't get you out of restraints in under an hour if we're properly medicating you. Other thoughts on meds as we kind of breeze through this. Remember that not every med needs sedation, particularly in the outpatient clinic. In the ambulatory setting, it's very good to often give meds to just calm people down, reduce their anxiety. They're having a tough day. They need to talk to you. Hey, can I move you back about 30 minutes? Let's try this med, get you some water, get you a snack from vending. I'm going to go see somebody else and I'll be back. That's a really good way to handle things. And it shows trust and it shows a non-dichotomous approach, if you will. Now, when it does come to meds for these things, because they do play a role, a lot of different things here. And I think it probably is going to come down to this article. This is relatively new, about a year old. Well, not even a year old, which shows that the best evidence is the route, not necessarily what med you pick, which I can tell you I've seen. I used mostly sublingual options when I was in a PsychER. They work faster. They avoid most of first pass. People don't cheek them and they work quick. So I can give it to you and come back in 15 minutes and you felt something and we can have a conversation. So I think as this moves forward, you're going to see more and more sublingual and intranasal options. That loxapine is actually an excellent intranasal option, but it has a REMS behind it for bronchospasm. So if you're ambulatory, I don't know if they're going to want you to use that, but it's really nice. It's an inhaler. A patient can use it themselves. It's very nice. It's just kind of that REMS has held people back. All right. When we're doing this, we're not just doing this for your safety. Your safety is most important. That's why we should be doing it. But since we are all part of a much larger system, it's important to also look at this component. Reducing workplace violence is good for business, period. So for those of you in the room that are like me, that are a little bit more administrative in your career than clinical, this is better for patient satisfaction. It's better for staff satisfaction. People can't find qualified staff. Well, guess what? If they're getting hit and threatened, they're not going to stick around. There's a business case to be made for doing this, not just because it's the right thing, not just because it's best for the patient, which it is, it's best for the staff, which it is. It's also good for your system. It's going to lower your throughput, lowered length of stay, less grievances for all you managers out there, and better partnerships with all of your stakeholders. And don't forget that if we're talking workplace violence, you got to talk guns. And we got to talk guns as a public health component, okay? There's a lot of arguments about this. This is a separate passion project of mine. If you want to learn more about this, I have a lot of info online that is free. Just Google my name and talking to patients about guns, and you'll get a bunch of free webinars. I do think we should be talking to patients about this. I think us not talking to patients about guns when we're worried about their safety is like, cardiologists not talking about smoking. It's a very clear risk factor that we would not want to ignore. And unfortunately, as I give you here in some of this Rutgers data, we're not good at it. Docs as a whole, of all specialties, it's not like psychiatrists are good and other doctors are not. No, we as a whole are not good about talking about firearms with our patients. I think it's very uncomfortable for folks. They feel it's political. They feel it's controversial. I always come at it from a public health standpoint, just like I would talk about smoking, car seats, seat belts, et cetera, et cetera. Now, what's really interesting here, this is more Rutgers data. Who gives the message is very important. You would think that we're a good person to talk about it, but in reality, when you kind of survey the public, most people, we are pretty low on the issue. Down here, I'm going to put my scroller by it. Least credible sources to discuss firearm safety: celebrities, casual acquaintances, and physicians. So I think we got some work to do. That may be a data point that is because we're not doing it well, we're not doing it enough, or the wrong people are the ones representing us. That I don't know, but it's worth noting. Now, a word you may use a lot with your patients, since we're going to talk about threats and mitigating threats over time, is storage. And I'm always a big fan of, they've had to change this name. They always used to call it safe storage. The problem is most people that own firearms already believe they're doing it safe. So if you say safe storage, they stop listening. Like, yeah, I store everything safely. So really what they've gotten into is the word secure storage, which is a different way of doing things. Unloaded, gun safes, et cetera. Once again, not the predominance of today's topic. I just want to give you some things to think. There's more of this online if you want to see my thoughts on it. So I always, with all of my patients, do you have access to firearms? What type of access is it? Not all access is the same. Why do you own them? Open-ended. It's a great way to kind of dismiss the energy and the emotion. People like talking about their firearms sometimes. It's an interesting topic for them. And when they see that you are approaching it in a non-judgmental fashion, you are going to get a lot of good info. Then I can lead into, how do I store? And are you aware of the risks that they pose? Don't assume that people understand that firearms are risky. I have worked with workplace violence where there's a spouse. So the person you're concerned about is a patient, but the patient has a spouse. A lot of the education to do with the spouse is, hey, listen, I'm worried about your significant other and how they feel towards our clinic. Do they have guns at home? Oh, yeah. Well, do you think there's a way we could get the guns kind of out of the home while he or she is so upset? That alone is probably the most risk reduction we can possibly do, but we very rarely document that we've tried it. So it's something worth considering. This takes practice, but once you get used to it and you work it kind of into your social history or into your counseling portion that you do with other public health items, it's really nice. So let's get on to systems. You heard me say this earlier. This is a great group. I belong to it. It's a multidisciplinary group of physicians, psychologists, Secret Service, FBI, CIA, law enforcement, both local and national. But the idea is, how do we follow these threats over time? Threat assessment as a field is well evidence-based. Tons of articles came out of law enforcement, but really uses multidisciplinary subject matter expertise. And it follows cases. It does not believe that a case can just be solved. Somebody's not always just going to be high risk or low risk and nothing in between. The truth is, when people are going to be violent to you at work, or there's going to be a workplace violence episode, most people tell somebody. Almost always. 4 out of 5 times. They either leak or threaten. And if you're not familiar with those two different things, leak means you tell somebody else. So a threat would be, oh, you're firing me? I'll see you tomorrow and see how you feel about it then. That's a threat. A leak would be, they go to clear out their locker Their friend has the locker next to them, and they tell their friend, hey, listen, you've been really good to me all these years. Do me a favor. Don't come to work tomorrow. Now, they're not threatening them. They're not saying they're going to do it, but they very clearly have leaked their plans. Some of the most important events that have been stopped, and by the way, a lot of these are stopped. They don't make the media because that's not quite as sexy, but a lot of events are stopped. It's because of leakage. People speak up, they post something on social media, because the truth is people don't snap. That's not how this works. The media portrays it that way, and that's very unfortunate, because that then leads you to feel disempowered. And you feel like there's nothing I can do. It's going to happen. Bad things are going to happen. Most people, these things are not snapping. These things are planned. Unfortunately, they're very well planned. That's usually why they have high rates of fatalities. They think about it, they dwell on it, it becomes a grievance and a grudge. People will practice and do dry runs. People don't just snap. Now, the good news about that is there's lots of time to intervene. There's lots of times to make things better. Because in threat assessment, we are trying to prevent, not necessarily predict. We are looking to intervene, not prosecute. And to be honest, there's a lot of good data on how to predict for things, but it's very much like your heart attacks or your MI protocols. I know who is likely to get a heart attack. I can even stratify you in so much risk within this year versus 5 years. Can't say what day it's going to happen. I can't say you're going to have a heart attack on Friday, September the 6th, or Friday, September the 20th, or whatever it may be. Very similar with threat assessment. We know who is at highest risk. We know who we're most worried about in the next couple months, but you can't pick the actual day. But you can say when you're going to be at higher risk. And it does work in healthcare. Many healthcare systems, I don't know if UW has already done one, but they have multidisciplinary teams. Physicians, nurses, HR, security, EHR, IT. Oftentimes your risk assessment and your corporation counsel will need to be part of this as well, and some C-suite representation. How do we follow these things around? Now, HIPAA is often the most misunderstood thing. It's often used inappropriately, often by us. HIPAA has a myriad of reasons to make exceptions for disclosing information if you think there is danger involved, and that's the key. It's not about did you break confidentiality, did you explain why you broke confidentiality. Always got to bring this up. I mentioned a couple of these 45 CFRs here. Probably another one of my most important slides. And it's not mine. I borrowed it from other people, to be fair, Weston and Calhoun. This is how I visualize workplace violence. People do not show up for your intake, and all of a sudden they're at the top step, which is attack. They start at the bottom. They start with a grievance. They're pissed about something. They feel it has not been resolved. Then they start dreaming, ideation. I wonder what it would be like to blah, blah, blah. Then they start researching it. That's where a lot of people are caught, is in research. Your online anonymity is not anonymous. And so a lot of times things are caught in that fashion by law enforcement. Then they start preparing. Then they start breaching. Breaching is practicing. It's looking to see how quick police times are, looking to see which doors get locked during fire safety drills, things like that. My point being, though, is you can walk people back down the stairs all the time. We use this terminology all the time in threat assessment. We got this guy we've been following. His name's Tony. He's been living in the grievance world for about a year. However, we're a little bit worried that he's moved up to research and preparation. Can we go talk to him in his home for a little bit? That's what a threat assessment team would do. Walk them back down the stairs. And if we do things poorly, we can accidentally escalate things up the stairs too. But think about this. This is how threats towards workplaces work. They work themselves up the stairs. They don't just something happens and then they're at attack phase. There is room to intervene. Each one of these steps has different things we can do. Don't worry alone. Nobody snaps. I'm going to move past a couple of these slides for time. There's a couple things I want to get to. All right. I said we talk about this. There are some things that whenever workplace violence comes up, people talk about this, and they should. How do we get them out of here? I want a restraining order, and I get that. Once again, I want to come to you that I'm not just doing this as like my expertise. I have personally been stalked. I have people give me the address of my home and where my kids go to school. I know what it's like to be very personally under the microscope of a very aggressive patient. That being said, evidence would say that most of these things like 1 and 2 don't work very well. First off, can you fire them from an outpatient clinic? Sure you can. You can't from ER or inpatient, but you can from outpatient. You can have a protocol for that. But that doesn't keep them from coming back at all, right? Unless you've got some sort of special fence around your place. People can get in. People can come do horrible things, despite them being a patient of your clinic or not. So I would take that decision very, very seriously and consider some other options. One reason why this doesn't work and why restraining orders don't tend to work in healthcare is very simple. Punitive actions would work on people. And if they would work on those people, they're not the people you're worried about. If it's somebody that could be turned away by a threat like that, or a restraining order, oh my God, you got a restraining order? Well, then I will behave. If that was the case, they wouldn't be somebody you're concerned about anyway. They're very low risk. The people we're dealing with are high risk. They are zebras. They are not horses. And as such, they are not going to respond to these typical things. There's some great data on restraining orders. I highly suggest, this is a free article. You can find it online. Dr. Sheridan Ryan is a psychologist who runs the a lawyer who runs the threat assessment team at the medical college. So your sister academic institution in Milwaukee. This is a really good work on the data behind restraining orders in healthcare. They are very poor, very, very poor, to the point of, it's not like we don't do them, but I really caution people. And there's a worksheet that's attached to this article that you'd want to work through before you decide to take this step, because there just has not been tons of evidence that this is very therapeutic or gets you what you want. Now, EHR alerts can be very good. That can be part of a good threat assessment team, is alerts on certain people, their behaviors. That's all fine and good, flagging things. However, they need to be regulated. They got to be reviewed, and they have to be actionable. If you're just putting one there and then you don't do anything with it, that doesn't help. It has to be something that is reviewed by the threat assessment team at their monthly meeting or whatever to make sure that it is still accurate and up to date. Otherwise, you do run into some points of bias. Behavior contracts are very similar to restraining orders. Organizations do them all the time, and there's no evidence they work. I'm not going to sit here and say if you're doing them that you're wrong. I think when you're scared and we're trying to make things better, we're going to try a bunch of different things, right? So good for you. But the data would say this doesn't really, because once again, if somebody would respond to the idea of signing a contract, they're not the person you're worried about. Just like contracting for safety back in the 80s with suicidal patients was a horrible idea. It's actually one of the most sued things about it if people are still doing that. Because if somebody could sign a piece of paper saying they wouldn't do it, then they probably weren't suicidal to begin with. And I mentioned this earlier, but I do tend to push into it, if you guys ever want to talk about this in more depth, how we handle dissatisfied patients. Not only is it good for reducing violence, it actually binds patients to us. There's a lot of studies that if you have two companies, company A, company B, company A has never given you any trouble. Company B, there was trouble, but they fixed it quickly and to your satisfaction. People stick with company B longer, even if company A's never had a problem in their work. But the idea of, we had a hiccup, we hit a bump in the road, and man, did you come through for me in that moment, really binds people to you longitudinally. It really is a long-term risk reduction. And when I say service recovery, this does not mean the customer's always right. Around apologizing for everything. You may not have been wrong at all, but we still need to hear people out. What I often tell my patients or my docs is, just because you became a doctor doesn't mean we get to say, I was right, therefore why should I say anything else? Just because you're right doesn't mean people still won't be dissatisfied. There's still some degree of public service, public relations, humanity that we've got to do with patients. Now, I'm not a huge fan of satisfaction scores or satisfaction scores being tied to compensation. That is a separate issue that I think gets conflated into this at times. I think we can be human beings that deal with grievances that doesn't have to come down to a numeric value. That's my own personal opinion. Weapon screening is great. Actually, there is decent evidence for this in hospital and ambulatory settings, that usually you will find weapons that you would not think were there, or people forget they have weapons on them. I don't know how much of that you have in Madison. We have some of it in Milwaukee, where people honestly carry all the time, legally or otherwise, and they forget that they had it on. And they're like, oh my God, I'm walking into a hospital. Of course I can. Here you go. So I think there is something to this if people are willing to make the investment. Now, what are some resources for you guys? I would say these are the biggest three. ATAP is for everything. ATAP is, for threats to the courthouse, threats at schools, threats at picnics and convention centers and hospitals and clinics. So it kind of covers, it's kind of the big broad one. There's not as many healthcare people in that, probably. IAHSS, however, is the healthcare variant of that. That is the International Association for Healthcare Security. So if you're into healthcare workplace violence, I think that one is probably more worth your investment and interest in their resources. And I mentioned MCW's got a really good threat assessment team. I can say that I don't sit on it. But I consult to them at times if they need things. But they have a separate conference they run here in central Wisconsin that a lot of health systems come to. We're already booked up for this fall, but if you look it up, it's called the MCW Threat Assessment with a focus on healthcare workplace violence. And it's a very intense 3-day stay. People usually send multiple people for their system. I am one of the instructors, so this is not a completely unbiased plug, but we sit there and we basically live with you for those 3 days, and we work scenes and we work cases. It's not just all didactics and PowerPoints. It's a really cool thing. And we get people from all over. I think this year we've got 12 systems coming in from 10 states. So it's not just a Wisconsin thing. People come from all over to kind of learn this way of mitigating risk systemically. A couple other resources. If you're wondering, like, man, this guy went through this stuff really fast, how am I supposed to remember what to ask a patient? That's what ThreadAid is for. UC Davis has a wonderful public health website on firearms in general. It's called Bullet Points. But this is the separate free website, free resource that a bunch of us developed called ThreadAid. You can download it to your phone. So when you're working with a case, you can pull that up real quick and say, okay, have I covered this legally? Have I asked these questions? Have I documented this? It was meant with the active kind of outpatient provider in mind. It's called ThreadAid, free to use. I quoted this article earlier. I do believe this is open access. If it's not, email me and I will get you a. This is probably the best overall. This is written from a colleague of mine at UC Davis and a colleague at Pitt. That really looks at the mass shooting component, which I do think people think about very often when they think about workplace violence. This is probably the best summary of how to interview, assess, and handle people that you're concerned about. It's just that good, and that's why I call it seminal. If you get a chance, I think this is, and it's very short. I want to say it's 3 to 4 pages. It's not going to be something that'll take up much of your time. And the most recent thing I can share is something that just popped. I just added this article this morning because it just got published 2 days ago. So it wasn't in my original slide set. My apologies to UW for that. This is an addition. This was published in the Healthcare Security Journal. This is myself and a colleague of mine from Pitt, Dr. Roselle, called Beyond Tackle and Shackle. And we wrote this for security professionals. So why am I sharing this with you? Because once again, just because the physician workforce and physician leadership knows how to do this doesn't mean workplace violence will automatically decrease or be mitigated. You have to have everybody buy in. You have to have all scopes of practice and people that work with patients buy into this. So this was purposely written for kind of the average consumer. So if you guys, this is free access, I know. So it's out there if you want to spread it around. It's a real nice read. It is not meant to be physician nurse mediated, but kind of security, HR. Do you work with patients in healthcare? How do you do so in a safe fashion? And with that, I know we went through that very quickly and in many items, but we do have some time for questions. And so I will defer to leadership of the Grand Round Seminar and which questions they want to start with. Thank you.
Great. Thank you. I'm going to jump in first, and maybe Betsy Trowbridge has a question about how we can get our health system to develop a more comprehensive plan. So I'm going to suggest perhaps that Betsy, who's our division chief of GIM and our head of our primary care and ambulatory area, is connect with you afterwards and brainstorm, because I was looking at your threat assessment, how can we do something or bring something similar to UW Health? So while I'm not going to answer that question, but I think this is an important topic that would love to leverage your expertise and your frequent visits to Madison.
Yeah, I'd be happy to help. I dropped my email in the chat again, so they can reach out to me and we'll set something up. It is definitely something that is, I think, very worth doing. Schools have now started doing it. Schools are almost being held accountable to have it, and I think healthcare will eventually too.
Yeah, great. Okay. Hand it off to Siobhan.
Right. So, Tony, thank you so much for this talk. But we had a couple of questions about, well, first off, saying, love your practical talking strategies and cheers for the goodness you're putting into the world by doing the work with compassion and clarity. So thank you so much.
Thank you.
A question about, would you advocate that clinics stock emergency antipsychotics?
I've seen it. I've seen it and it works. I think the key there is getting the staff to understand we're not staffing, we're not going to have IMs there for us to be holding people down in the waiting room and traumatizing everybody. But people have bad days. If people came in with chest pain, we would give them a nitro for their angina before we met with them, right? I mean, this is no different. If they're anxious and you have some on-hand things, antipsychotics are often the number one go-to in a sublingual formats. I've seen clinics do that with risperidone M tabs, Zydus, the dissolvable Zyprexa. There's a dissolvable Abilify, but it's super expensive. I wouldn't suggest it at that price point. There'll be other dissolvables down the road. I do think it helps. And in benzos too. Now, you got to be careful with benzos, right? So we're not getting down the road of people are just asking for benzos at their appointments. But there are times where, using 1 or 2 benzos to mitigate a scenario is not going to make any substance use issue worse. So I definitely advocate that. What you'd want to do is tie together your P&T committee, your med staff, and probably whoever does risk for your group, and just make sure you've written the policy in the way that you like it.
Thank you. Another question, probably based on both your expertise and your personal experience, but can you speak to recommendations for how healthcare workers should recover and endure after they've been credibly threatened?
I'm glad somebody said this, because with all these slides, I don't have time to get to that. When you are hurt or injured, it doesn't vanish, right? It's very natural that it's going to be something that sticks with you. And I really hope we as a system can find a way to support you so that you can keep on doing the great work that you do. Because to be honest, losing a provider is far more powerful than losing a patient, because you guys are going to treat tens of thousands of people in your lifetime. So purely in just an impact fashion, we want to make sure that you're okay. I think everybody's different. I don't think ignoring it works. I don't think just, oh, it happens. It's, I hear all the time, well, you're a psychiatrist. You signed up for this. No, I didn't. Nobody signed up to get hurt. So I think the key is, first of all, for that individual employee, for whichever doc we're talking about, what is your typical way of handling any stress? Is it with family and friends? Do that. Is it through further hobbies? Fine. I think it's nice if the supervisor and or department has an option for them. Very often people have Balance sessions, speaking sessions. You never make it mandatory. You never want to say to somebody, you've been assaulted, so therefore you must go through this kumbaya session after work once a week for a month, and then I get to check off that I did it. That doesn't work. But I really have found, as a supervisor who's worked with a lot of people that have been assaulted, is I think it's often the subacute period, not the acute period. It's the subacute. The acute, people just want to get back to work, and you're just kind of freaked out by it. But it's usually a month or two later. I like to check in with them and say, hey, listen, I know we went through a lot back in, say, June. You want to grab a coffee and we can just chat about it? I think that vulnerability and the willingness to do something outside of work is very powerful. And just allow yourself to be human. It will affect who you are. It will affect how you face patients. I can tell you there's certain types of patients I still have an interesting countertransference to. And when I wonder, why am I feeling this way? I remember, I got attacked by one back in the day. I've mostly blocked it out, but I remember it. And it wasn't an attack. It wasn't severely hurt. I didn't have to go to the ER, but I remember it. And so I think those things codify in our hippocampus. So just allow yourself to know that despite you are all incredibly intelligent professionals, these things affect us like they'd affect anybody else. So I think there's absolutely a way forward, but it has to be something that is both unique to that person and how they heal, while being backed by the system. And I think that's really important, is that the system understands it. If people need some time off, I don't think it should ever be mandated or assume that everybody recovers the same. I have seen, resiliency is something we don't understand yet. We've done a lot of research on it, but we do not understand it. Certain people just bounce back differently. Doesn't mean they're tougher or cooler or better. Maybe they're more genetically blessed, if you will. But for some people, it's a different phase. It's a different type of process. You just make sure as a system, you give them room to get what they need. That's what I would suggest. But you definitely can recover 100%. And sometimes what I have found is those become the best advocates for systemic change in workplace violence because it's personal.
So yeah, I have another couple questions. I'm going to pull one from a little later because it follows on directly. Betsy's asking about if you have a whole clinic that has a high penetrance of PTSD over an incident, how do you address that?
Definitely once it's over, never that day. Let it all simmer. And then you got to talk. Now, this is also, if you set up a workplace violence thing, you'll be doing this anyway. But anytime there's been a full clinic scenario, something where everybody got hurt, either was involved or heard it or saw it, patient in the waiting room or freaked out by it, whatever that may be, you meet with the staff and you talk about it. I don't like to call it an M&M because an M&M has a pejorative context. And I also don't believe that just because you had an incident of violence that something went wrong on your end. You guys may have did everything. We don't want to ever make a blaming culture. What I like to call it is something went askew. Let's at least talk about it. Let's make sure we covered our things, and was there anything else we could do differently, and let people speak their mind. And what you'll find very often is that's the time when people are willing to speak up. They typically don't want to speak up proactively, but once something has happened and people have been affected, like this incident you mentioned in the clinic, you'll hear from your security staff. You'll hear from your front desk. I think some of the most important people to train in this is front desk workers. A good front desk worker will mitigate risk incredibly well. And somebody who's not so skilled can make your life very difficult. Not because they mean to, it's just because this is not their forte. So I think this allows all scopes to kind of talk about how it went down, how people feel. There's going to be a lot of time for people to view the emotion as, well, I don't want to see them ever again. I need them out of the clinic, which is, by the way, Completely understandable. So have that conversation. Say we're having that conversation at high levels. But there are pros and cons to that. There's ups and downs to all of those decisions. Whenever it comes to violence, you are comparing risk to risk. It is never risk to no risk. So I hope that's is a bit of a nuanced answer, but I do think that there's a good way to do that. And I encourage group-wide, team-wide conversations. And make it what I tend to do to make it less worrisome, have it as a monthly schedule. So even if you got nothing that month to talk about, that's fine. People get a free lunch hour. But otherwise, once a month, pick up those near misses, those things that went somewhat off, and just talk about them. And that way people don't feel like anybody's in trouble for it, because it's always on the schedule anyway. It normalizes it.
Great. Well, we are at the hour. Thank you so much. Clearly a very important topic. There's a lot of interest, and I think there'll be a lot of ongoing discussion and hopefully some new ways to approach this in our workforce and our work settings. Thank you again, and I hope to see you in person at some point in the future.
It was wonderful working with you guys. If there's any parts of this you want to delve into more, just holler at me. It's been a real pleasure, and I appreciate all the hard work that you're doing in your area. Thank you.
Great. Thank you so much.